A vaginal rectal perforation after gender-affirming surgery, which results in stool leaking into the neovagina, is considered a dangerous complication of the procedure. Today I explain why this issue can occur, where the perforation happens, and how we treat it. The first problem starts with an accidental injury to the wall of the rectum during the creation of the neovaginal canal, which is a key step in the gender-affirming surgery. Naturally, the rectum lies very close to the space where the vaginal canal is being created. If the dissection goes too deep, it can cause injury and lead to a perforation into the bowel. If this happens during surgery, the surgeon will first close the rectal perforation before continuing with the neovaginal construction. If after surgery, the sutured areas heals well, meaning there is no leakage or infection, the patient won't have any further issue. But if there is leakage or infection at the suture line, the repair site can break down and eventually lead to rectal leakage. This becomes the second problem. Once leakage and inflammation begin, the infection can extend to the neovaginal wall, which is located right next to the area, gradually leading to tissue breakdown and the formation of a passage into the neovagina. This becomes the third problem. When all of these occur together, the patient ends up with a fistula, a hole connecting the neovagina to the rectum. In medicine, we call this a recto-vaginal fistula. If the fistula develops early, the first sign is often stool in the neovagina after remove the gauze. Or in some cases, the patient only becomes aware of the problem later when they begin dilation and notice stool discharge. To completely cure a fistula like this, surgery is necessary. There are a few surgical options. Method 1. The surgeon tries to simply close the hole in the vaginal wall. However, this method usually fails because the rectal tissue at the damaged area becomes weak and stiff with poor elasticity. That makes the repair fragile and prone to reopening again from friction or vaginal dilation. Method 2, which is much more reliable, is to perform colon vaginoplasty. The colon wall is thicker and provides extra support over the previous repair site. This technique also creates a new neovagina that is more resistant to friction and gives more depth. Since most patients with fistulas tend to have vaginal shortening from chronic inflammation, a good fistula repair must include turning the old skin lining inward and securely closing the hole. Then all remaining skin inside the old canal must be removed before performing colon vaginoplasty to reconstruct the vaginal canal. In the next episode, I talk about using colon vaginoplasty for cisgender women who were born without a vagina. Please stay tuned.